Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the institutions of any of our guests. Okay, so today we're in San Antonio, Texas at the 2024 annual meeting of the American Shoulder and Elbow Surgeons Society. And this has been a phenomenal meeting. There's been a huge number of great talks. We've picked a small subset of them and had the good fortune to have the speakers agree to come on and talk about their research, the work that they've done, and to go through with us, their findings and then their implications. This is just a small taste of all the great content going on at the meeting, and my hope is that you'll listen to this and it will inspire you to come to the meeting next year if you didn't attend this year, or at the very least to get a better look at all the research being done by all of our members. Okay, so we're sitting here right now with Dr. Ian Lowe of Calgary, Canada, and he's here to discuss his paper, The Natural History of Bone Remodeling Following Arthroscopic Distal Tibial Allograft with Suture Buttons for Recurrent Anterior Shoulder Instability, up to 5 years radiographic outcomes. Ian, welcome to the podcast.
Pete, thanks for having me here.
And then joining us as a guest co-host, is Dr. Eric Wagner of Emory. Eric, welcome to the podcast.
Thanks, Pete.
So Ian, tell us what inspired you to do this study.
Well, what inspired me was, in Canada, we have a lot of patients who have recurrent anterior instability. We don't actually see a lot of first-time dislocators, so our amount of bone loss in our patients is significantly high. And I actually reviewed my results of isolated Banker repair many, many years ago, even in patients which we now know have significant glenoid bone loss. And I was getting like a 30-35% recurrence rate. And so that inspired me to try to move forward and see and understand better which patients need bone loss and what's the best bone grafting technique.
Okay, so it sounds like you've then worked through a couple of different bone grafting techniques. This technique specifically is allograft with distal tibia, suture button fixation. Tell us a little bit what you found in terms of outcomes with that particular variation.
So this is actually a subset of a larger study. We did a larger clinical study looking at a kind of a cohort of 50 patients, which we prospectively evaluated. This is a subset of 31 patients where we had CT scans, basically preoperatively, 6 months, 2 years, and we had 10 patients go out to 5 years. And what we were really interested in is to see how this bone graft remodels over time. How does the shape of the glenoid look? How does it heal? That was kind of our impetus.
And tell us what you found with the remodeling of the bone graft over time.
Well, I think that's a very interesting thing. I think remodeling depends on not only healing, but also where the graft is positioned on the glenoid face. So what we found was that in general, if you can position the graft perfectly, it's going to do better. But if it's too medially displaced and or rotated on the coronal plane, that actually decreased your healing rate. And so, in 6 months, we had about like a 95% healing rate. And then about 2 years, we had about an 80% healing rate. So it actually decreased over time according to this position as well.
So medial makes sense. That bone is not loaded. What do you mean by rotation in the coronal plane?
So if you just look like at a coronal plane CT and you can see the rotation, so essentially the graft is not collinear with the the face of the glenoid. It's almost like you're looking at an AP X-ray. It's kind of rotated in that fashion.
So like maybe the inferior or superior portion of the graft is medial.
Correct.
A portion of the graft is not loaded.
Correct. And I think in part that's related to the medial displacement as well, but within the numbers available, we couldn't really correlate them together.
Okay, now there's significant debate in the field between suture fixation, screw fixation. Suture fixation is really pioneered by Pascal, and he's shown us it can work with autograft. This paper is one of the first to describe longer-term results with sutures with allograft. Based upon these results, do you think we can move away from screws, or do you think that we probably need more work until sutures can work for allograft?
I think we still need more work. I mean, we only had like 31 patients, so that's still a very, very small cohort, and that is partially, during our learning curve as well. And so we had some grafts. I mean, to tell you the truth, to have a perfectly placed graft, we only had like maybe 50% of our grafts that were actually perfectly positioned. And I think those grafts actually probably do the best because they heal the best and they reconstruct the glenoid the best as well. But it took a lot of nuances as far as the positioning of the bone tunnels, etc., to get that graft perfectly flush. And I think that's a huge learning curve because, when you're using indirect techniques, with, double barrel guides and all these other things, you don't actually know where the graft is going to go. Because those graft holes have to perfectly match your graft tunnels, and you have to have the graft tunnel position exactly match. And there's so many nuances related to that that what you think looks perfect doesn't necessarily look perfect when it actually gets reduced.
And so you think that's more a product of the suture buttress fixations failures is the graft placement, and that's why you're seeing potentially more resorption, or is it the initial stability that you're getting from the suture buttress fixation? So basically, is it positioning that's the issue, or is it the actual fixation construct that we need to work on?
I currently believe it's a bit of the positioning issue at this time, but I also believe that some of these constructs, because they're good with compression but not so good with shear, that the larger the bone graft that is required, therefore the increase in glenoid bone loss, that you're probably better off going with hard fixation.
Certainly, one of the newer iterations is the use of cerclage. Your technique is not a cerclage technique; it's a button-based technique, right?
Correct.
Do you think that we would have all the issues you just raised with tunnel position and the shear issue? Do you think they're going to be the same with cerclage?
I personally believe it's going to be the same. We had like a double button suture fixations. There's actually two, twin tunnels. I don't think cerclage really adds that much of an advantage over that. Obviously, there's some biomechanical studies that suggest maybe a little bit better, but I think it still will be not robust enough, to really prevent that shear force from moving the graft.
And so then, from the screw standpoint, does that help correct for some graft malplacement, or do you think it's going to be the same issue? So it's more of a positioning rather than that hard fixation with screws. So can screws make up for it?
Yeah, I think the funny thing about screws is I think screws will have a similar problem as well as far as positioning as well, in a sense that while you can directly see the reduction, that actual graft angulation between the graft and the articular surface is super hard to get. Like, we have actually done a whole bunch of screw cases as well after this study was performed, and we can get our positioning pretty good, like inferior and medial to lateral, but to get that articular angle to the graft, it's actually really hard to get that flat down at 10 to 15 degrees. Some of our grafts are, honestly, they're like 20, 25 degrees. And while you can get them in the heel and heal perfectly, we know over time that's going to remodel, the screws going to become prominent. I mean, those are things that we have to follow.
So tell us, based upon your results, what is your current preferred fixation methodology for distal tibial allograft?
I'm not sure exactly what's best, but from a study perspective, we're basically doing all screws right now to follow our next 50 patients and then do a comparison. I think for sure, if you have a 20% type of defect, I think you can probably get away with suture bunches with perfect positioning. But as that graft gets larger to 25, 30%, I think it's better to do screws.
Now, Eric, I know you're doing a lot of arthroscopic bone grafting in your practice. From autograft to allograft. What's your technique right now? What based upon what that you've read in the literature?
Yeah, fair. It's super controversial, and this type of data is really what we need, especially with regards to our move towards allograft. You interpret a lot of the historical literature. It's all from France and some other European nations on autograft, and that potentially compensates for some of these issues with positioning. Personally, what I do right now is arthroscopic LRJs for the vast majority of my bone block cases, with a couple rare exceptions, the really large bone defects when you're approaching 25-30%. But then that comes with the same issues that you have with, and you brought up with the distal tibial allografts that we're seeing. And then posteriorly, I'm doing exclusively distal tibial allografts all through the scope. For me, the arthroscopic LRJ, there's a couple of reasons. One, a large percentage of my patients are recurrent instability, failed Bankart, failed or even the setting of EDS, and in combination with bone loss. So there's a soft tissue defect that I sort of want to help to make up for as much as I can. So it's not just the bone that I'm trying to replace. And two, I'm still resident. We have a study coming out on our posterior bone blocks where similarly we got CTs at 2 years, and it's interesting with the DTAs as opposed to some of the autografts that you do see remodeling, you do see reabsorption, and it is position dependent. But I have a great case I like to show that's like a perfectly placed glenoid, perfectly placed distal tibial allograft on the posterior glenoid. We have dynamic imaging showing the patient's recentered, yet the graft is changed from 3 months to 2 years and started resorbing. I can't explain it. So I do think the allograft is something that I think we're still learning about, and I do it with screws.
I totally agree with you. We actually had one case in our study where the patient started with a 30-35% defect. We did a distal tibial allograft and they resorbed. Now, they didn't completely resorb back, but they still, at 2 years, had like an 18% defect. So it's like, okay, it's better, but it's not perfect.
Yeah. It's so interesting.
What's so interesting to me about that is we think we know with Wolff's Law that that's about loading, but I think we don't know dynamically how is that bone really loaded, and does that differ neuromuscularly between patients, and does that differ depending upon larger factors with the morphology of the scapula? I mean, there's so much still to learn about shoulder instability, and this is what's so exciting about being a shoulder surgeon.
Yeah, for sure. And if you get some of these, I mean, I know, Peter, your guys' institution, you have a great biplanar setup, but if you look at some of the dynamic motion after these grafts, you see some people are actually centered, and even though the graft is well positioned, they're actually like probably not loading it as much as you think. Other ones are literally like loaded on top of the graft. The head's like decentered on top of the graft. Clinically, they're doing fine, but it's fascinating to me why there's a difference. What's going on? Is it a scapular mechanics problem, as you know, especially in the posterior setting? Or is this a graft problem? I don't know. I'm unsure. There's so much cool stuff to learn. That's what's beautiful about like studies like yours. I think the highlight of this compared to what many of you have read out there is there's not that many studies getting multiple points, understanding what happens at time point 0 or time point 3 months, and then 2 years, and then beyond that. And that's, I think, truly understanding how to do these techniques. From my perspective, it's that data that gives us the idea of the type of fixation, the type of graft, the size, the parameters, how much you're trying to make up for. All that stuff is really critical. So congratulations on a like truly phenomenal work.
Yeah, I think this work is it's difficult to overstate the difficulty in doing this kind of work.
For sure.
When you talk about the length of follow-up serial CTs. So congratulations to you on this. Congratulations to our, on continuing the work now to repeat the same thing with screws, because I think that comparison side to side is going to be really what we need to understand what's better. And that work's going to be so important for the future so that we can do the right thing for our patients.
I think you're right, and I agree with exactly what you're saying, Eric. Like, I think there's going to be this nuance between the type of fixation, the type of graft. That's all going to make a difference about what the best reconstruction is going to be.
Yeah, beautiful. What do you see in the future? What's 10 years from now? What are you going to be doing? Do you think? What do you hope you're going to be doing?
Well, I think the hope. Honestly, I hope I'm still doing allograft just because the patients I feel like just do less morbidity, all these other things. And we're actually trying to do a study in Canada, Lactarge versus DTA, randomized. But every time I talk to a patient about the two different procedures, they're like, I don't want to have the Lactarge right now. But I'm like, that's the one that works. It's got the longest. And then they're like, no, let's do the other one first. I'm like, I have to change my preoperative talk or something like that. But I hope I'm doing TDAs, but I have a sneaky suspicion we might be doing Lactarge still.
Beautiful. Peter, what about you? Ideally, what are you hoping to do? What are you hoping 10 years from now? How are you? How's your instability bone graft procedure working?
Honestly, I love the distal tibial allograft, but I have difficulty agreeing with Ian that the Lactarge might be past, present, future.
Yeah, it's so fascinating.
But really, what we should be doing is just operating on first-time dislocators.
So
That's what we should be doing.
Don't end up having to do this at all. Well, thank you so much for coming on. This was great. We really appreciate it. I'm sure listeners will appreciate it. Congratulations again on your work.
Thanks, Pete.
So next up is Dr. Robert Hotchkiss from the Hospital of Special Surgery in New York City. He's going to discuss his paper, Long-Term Outcomes of Osteochondral Autologous Transplantation Surgery in Adolescent Athletes for Capitellar Osteochondral Dissecans. Bob, welcome to the podcast.
Thanks. Glad to be here.
And joining us as guest co-host is Dr. Mark Morrey of the Mayo Clinic. Mark, welcome to the podcast.
Thank you.
Okay, so Bob, it was a great podium. I want to ask you, what inspired you to do this study where you're looking at long-term outcomes?
Well, you might want to begin with what inspired me to say, why should we do this procedure in the elbow of an adolescent to 11-year-old to 14 or 15-year-old? Because at the time, they weren't really being done. There were a lot of other procedures, and it really was the frustration that we all noticed from just clearing out the hole that these kids continued to have symptoms. Mm-hmm. So I said, by the way, it isn't much of a leap. It's not even analogous in the sense of analogical thinking. It's, hey, it works in the femur. Why wouldn't it work in the elbow? Mm-hmm. And the question was, could we find a suitable donor?
Mm-hmm. So tell us the procedure. It's autograft, so it's similar to mosaicplasty. You're taking plugs from the knee and putting them in the elbow.
Yeah, and what's the difference between mosaicplasty, as I sort of investigated, they look more like hair plugs. Mm-hmm. And I found it a little bit sketchy, the after reporting as to how they worked. And I thought, because I helped people at various times do these in the knee for unrelated reasons. But what I was impressed with, it was a single surface composite graft with their own bone and that very important anchoring tissue to healthy cartilage. Because cartilage lives from diffusion of nutrients in the synovial fluid. It doesn't get them from the bone underneath, but if it's not attached, it doesn't work. And the interesting thing about that composite donor, that autograft, is it comes prepackaged, ready to insert. You just have to do it well.
So, okay, so this was what you were doing long time ago, and now you're presenting long-term results. What did you find were the long-term results?
Right, and again, the question about the study, I think, is important, because a lot of times we sort of say, yeah, I think it all worked. But I thought it was important to say, what actually happened to these young people in the out years? Because, you know, they grow up, they go to college, they do all kinds of things. And so we tracked everybody down now to around 30, and half the group are past 20 years, or sorry, 5 years, and some at 10 years of time from the implantation. And what was fascinating is some of them had actually forgotten that they'd had the operation.
Yeah. And they're still young. I mean, we're talking kids in their 14, 15, 16 years old. And
some in college now.
Right. And now if they're 25, they're still a young person.
Yeah.
So.
And it was really useful to, and again, there was a little bit of a small cohort that hadn't done quite as well. They had pain relief, but they were patients we'd gotten to a little bit later in the cycle, and they'd already developed inflammation in the joint. And they tended to have a little less mobility. They had a bit of a contracture.
So talk a little bit about that. I that's something that I think in terms of the decision making is difficult for people when you're treating these kids. Is there a point at which it's too late, or you wouldn't consider doing an osteochondral graft, autograft, or you would do other things, or are you pushing the envelope? Tell us a little bit about the decision making behind when or when not to do this.
Sure. Some patients that you see later on, and by the way, they don't really develop the end-stage arthropathy that you do see in certain, and they're generally 20-year-olds and 30-year-olds, that sort of thing, and you find out, oh, they had this problem, fine. It's when they develop a fixed flexion contracture, and the pain has been there, I'll just say, for more than a year. I think now you're really risking not getting a good result. So to me, the signal is delamination of the cartilage on MR. And one of the striking things about a lot of the studies being done is people report the condition without MR. Mm-hmm. And so they can't possibly stage it because they're trying to look at symptoms. And you know, when you're 11 and you want to play a sport, and the parents, you know, relying on them to be the signal of, oh, it's time to do the operation, isn't really very credible. So it's important to establish, are they having pain? Is the pain there all the time? Do they have synovitis and an effusion? Because that synovitis is actually destructive to the rest of the joint. And I think that's something that we just didn't appreciate. I didn't.
It's interesting. A lot of those kids then end up looking like they have rheumatoid arthritis because of that. It's a phenomenon that is, we see it, but it's like, why is this leading to such destruction? And if I could just ask a question, and this is really, you're looking at the cartilage delamination, but is this any size of a lesion? Are there certain locations where you're more apt to do a graft, or we've talked about the lateral buttress or more toward the trochlea? Does it matter to you, or size in your algorithm for a graft? So
most of this cohort is in the capitellum, and it's somewhere on that clock face, and none of these, I take that back. I had a few on the very posterior corner that there wasn't much of a wall there. So in two of the cases, I had to use two plugs to fill the gap. But quite frankly, I don't really worry about the last, we'll just say, 20 degrees or 10 degrees in full extension, because the radial head is robust enough that it can, if you load half of it in a push-up, it's going to be okay. So to go back to other locations, I've had patients who've had it in the over on the medial side of the trochlea, but what's interesting is they weren't having so much, they had a little bit of pain, but we followed it and they never delaminated. And so I don't know if it's a different animal over there. So there's something about it. Quite frankly, we don't understand where this comes from.
Yeah.
So some infarct happens in the bone or something where it loses its blood supply, because the bone is dead in there. That's the one thing.
Yeah, subchondral fracture leading
Right.
to loss of the blood supply. The etiology, we're not going to know, I don't think, but a lot of postulates. Go ahead, Peter.
I was going to ask you about size.
Oh.
Certainly it seems like this technique is more amenable to small size than large size defects. In your practice currently for larger size defects, are you using allograft or are you using?
No. So, well, let me make sure I understand what you mean by size, in that if in fact you can now get you can use a 12. There's a way to harvest a 12 millimeter in diameter, and I've only used that once. 90% of them have been between 10 and 8, and then I've had some that were 6. But can you do an entire, hemi part of the capitellum? I always try to think of where do we need coverage for load bearing, and the very external outside rim of the radius, the capitellum, probably doesn't see much. In fact, I've used that to harvest Oates grafts for the metacarpal.
Oh, so go into the elbow and harvest the thing that we're trying to preserve.
I know that sounds a little crazy,
but it does, Bob.
But it's in the very upper lateral quadrant, and I've checked this out many times. The radial head never goes there. Our embryology confers a lot of places that aren't really engaged in joint loading or anything, which is why you can use that section of the femur.
Yeah. And that's the question that I wanted to ask, is in terms of donor site morbidity. So we've talked about location, we've talked about size, but have you seen problems at the knee for donor site morbidity? I mean, there are some reports that report as high as 10% of a donor site morbidity, but has that been your experience?
I always tell people to be suspicious of somebody that says they've never had any, and quite frankly, we just haven't had any. But again, I don't harvest. One of the sports guys does, because they do it on a regular basis, and they put them in a brace and they start walking the next day. And at 3 weeks they'll come in and they say it's a little sore. At a month they're up running again. So I think it's the key to it. And by the way, of the sports, they backfill with one of those, not the plugs, but the forgotten what it is,
like fibrin glue
yeah. And who knows if that matters or not. But we just haven't had, and all of these kids play lacrosse, baseball, football, so
they never have downtime either.
Yeah, and they're running, all the time, and we just, and I remember the presentation ahead of me said that, they'd had some problems, and I guess we've just been lucky, but we just haven't had any.
These long-term results you present with grafting are very good. I think if you look in the literature, the results of grafting, both allograft and autograft, to be honest, are really pretty good. Is there a role still for arthroscopic debridement? I guess my main question for you is, when you approach these in your practice, you look at these results, is it hard for you to convince yourself not to say, why don't we just do the graft as the first operation?
Yeah, it's one of those questions where, because I try to convince a lot of patients not to have surgery, on a lot of things that we do, because, they've been recommended to have X, Y. This is different in the sense that the certainty of outcome to me is almost overwhelming. And if these kids have pain and they have an effusion, going in there and just cleaning it up doesn't answer the bell to me. It doesn't solve it.
Yeah.
And the solution is an outpatient operation that takes 40 minutes.
That really solves the problem, the underlying problem.
And the compelling part for me, and I've done lots of debridements, and we've looked at debridement over time, and it doesn't seem to have, at least at the long-term follow-up, any difference, at least in our study. But that is the long-term follow-up. Now we're getting 10-year data, 15-year data, 20-year data, and if we understand that, and then we may see a separation, which matters a lot it may not matter in their 80s, but it matters in their 20s or 30s or 40s, and so I think that's going to be the really exciting thing moving forward with the research.
And again, these kids are young people because they advance into, one of them played, collegiate level tennis, and at that point he'd had to stop. I have a Division II quarterback in football, and that was his throwing arm. And so, those don't just happen, and they have, the gymnasts and so on. So to me, there's something both sort of philosophically pleasing about taking cartilage safely from a place that's their own and putting it in, and you're done. I just don't have many operations like we don't even do any rehab.
Well, and there's, I think, very few operations we do where you can call the patient and say, the patient can say, I forgot that I had the operation. There's no patients with a shoulder arthroplasty or a rotator cuff repair or even a distal biceps very rarely says that. Most of them will say, right, exactly. Nothing's ever to say.
It's the pinnacle, right? The pinnacle of any
it's the ideal.
Joint replacement is, I don't remember which side I had done.
I've forgotten I had the operation. Yeah. Well, congratulations to you for this work. I think it's great to see the long-term outcomes. I think it gives us even further ammunition to push our treatment algorithm to make a graft the first operation. And I think it's, again, we need more comparative studies as you're doing at the Mayo Clinic. But I congratulate you guys for doing it. It's very hard to get people back that kind of long-term follow-up, and it's great work.
Well, the idea of solving the problem in a single event, to me, is what's so satisfying. As I said before, we struggle with all of our other things, so it's been fun.
Yeah. Thanks.
Well, thank you again for your time, and have a great meeting. Next up is Dr. Peter Domos from the Royal Free London NHS Foundation Trust, here to discuss his paper, Conserve or Reverse: Outcomes of Conservative Treatment versus Reverse Shoulder Arthroplasty in Displaced 3- and 4-part Proximal Humerus Fractures. Peter, welcome to the podcast.
Thank you very much for having me.
Joining us as guest co-host is Dr. Ian Byram of the Bone and Joint Institute of Tennessee. Ian, welcome to the podcast.
Thanks for having us.
Okay, so tell us the study that you did and what inspired you to do it.
So in my practice in North London, I look after a quite large population, an elderly population, so I see proximal humerus fracture a lot. And I noticed that when they come to our fracture clinic or trauma clinics, some of them, they really struggle if they're not treated appropriately, and especially if they have a displaced 3- or 4-part fracture. And that inspired me during my fellowship to introduce, I learned and I introduced a reverse arthroplasty in my institute, which was not highly used, especially after a profit trial in the UK, which was suggesting probably non-operative treatment is a way forward. So I started to use this approach and started to scientifically follow up this patient and see the benefit and cost and benefit of doing reverse arthroplasty and non-operative treatment.
So this is the highest level of evidence. This is a randomized clinical trial. How many patients did you have?
We had 99 patients, so it's currently the largest.
99 patients, so you have hopefully 50-50 of each. And then how long did you follow them for after surgery?
So there was minimum 2 years follow-up, because I feel like arthroplasty study needs to be at least followed up for two years. And the mean follow-up time was 53 months.
So when you follow the patients for 53 months, how do the groups compare? Like what do the two different groups look like at final follow-up?
So the final follow-up, we follow them up, not mainly focusing on range of motion, mainly focusing what matters to the patient. So we, instead of just looking prompts, we added MCIDs and a PASS score to really find out who is struggling and who is doing well. We find statistically significant better for Oxford shoulder score, DASH score, and subjective shoulder value for reverse, favoring reverse, and also all these scores were minimally clinically important difference. The most difference we found is a PASS score, which is basically asking a patient, do you find your function acceptable or not? And 90% of reverse were happy, and less than 50% of non-operative treated patients were happy.
So the reverses do better than the non-operative treatment. Now, there have been multiple prior studies that have compared non-operative treatment to operative treatment for proximal humerus fractures. There's like 4 of them looking at ORIF. There's ones looking at humeral arthroplasty. All of them, to my knowledge, have shown no difference. This is the first one, as far as I'm aware, that really shows that operative treatment is superior to non-operative treatment. Tell us, who are the patients that fit in the study? What were your inclusion exclusion? Is it just displaced 3-4 part? Were there age limitations? How do I know, based on this study, who I should be indicating for surgery?
So the problem with previous studies, a bit of a mix and match.
Right.
They have displaced, undisplaced, 2, 3, or 4 part fracture. They mix up fixation, non-operative treatment, and arthroplasty, some with hemi or reverse. My simple question was, over age 60, so all elderly, displaced 3 or 4 part fracture or head split fracture, excluding fracture dislocations, non-operative or reverse arthroplasty. I feel hemiarthroplasty in this patient, they're not going to benefit a lot, and fixation in this age group have quite high complication reoperation rate, 30% reoperation rate, 20% revision rate, or 30% complication and 20% revision rate, reoperation rate. So I do not offer this operation for them. The reason for that, because we did a systematic review before to look at acute and delayed reverse. And there was 2 other categories when you do the delayed reverse after a failed ORIF or after a failed non-operative treatment. Acute reverse outperforms delayed reverse, no question. Mm-hmm. But within a delayed reverse, if you do nothing, you do it after a failed non-operative treatment, they outperform after a failed fixation. So I fear with this high complication and revision rate for fixation in this elderly group, they do better if they don't want an operation to have non-operative treatment, and they run into trouble, we do a delayed reverse, then we try to be fixing these fractures, they fall apart, and then you push to do a delayed reverse with very inferior outcome.
So definitely, if you're going to do the reverse, I think we all agree that should be done early. And it sounds like your study really supports just proceeding to that treatment and not trying these other avenues where if they don't work, your reverse does not work as well as if you'd just done the reverse to begin with. I mean, do you think that's all accurate?
I see it. If the patient is fit for a reverse in a year time, because we try a non-operative treatment, is fit tomorrow.
Yeah.
And it's all about the functional demand. It's not really down to the comorbidities. It's really important the dominance, what they want to achieve. We know if the displaced 3 or 4 part fracture in this age group, they will not reach overhead function. And if it's a non-dominant side, they might be okay with that, but they will need to know. And there is all about discussion with them and give them an option. As I feel it usually does not happen. They just, have a sling, come back when you're in trouble. But they don't know the consequences. I always say to my trainees, there's no right or wrong answer, it's the consequences of our actions.
Mm-hmm. And it's interesting in the US system, where most surgeons are paid for what they do, you can look too aggressive. If you're offering reverse arthroplasty to an elderly patient, what would you say? I mean, do you feel like this makes the surgeon look like an aggressive surgeon if you're offering this off the bat? Or because I think, historically, we send these people home, they come back to the office in a week or 2, and then we sort of hash it out. But you would argue that we should just do it right then?
So, as I mentioned, I introduced this in my hospital, and all my colleagues, even my shoulder colleagues, thought, this is way too aggressive to treat them like this way. In the past, we just had the sling and very low revision rate or conversion rate to reverse. Literature suggests 5%. In my studies, our cohort is around 15%, ends up having a delayed reverse. So you might argue, but the problem is The reason for that, they don't want to go for delayed reverse because their complication and revision rate is higher. So try to sell them a much more complicated operation. They might say, oh, I'm okay, actually, I'm coping like this 1 year. So initially it felt like over-aggressive, but what I did, I just scientifically followed all these patients with serial x-rays up to 2 years and scoring, collecting this data. And then when we reached enough patient and power, publish it.
And then you had mentioned that some of these patients who didn't meet the MCID or they had a failure rate instead of the pass rate, how were they failing? Were they failing because of the operative side not being functional? Is it too painful? Or were you seeing even greater morbidity or even mortality in these patients?
In a non-operative treated patient, the problem is function, usually, that not the pain. Pain is not a major issue in our studies. Functional limitation, and mainly the functional limitation hits them in elevation, so they can't reach overhead, and this is a dominant arm. They start to rely on other people, they lose social independence, and some of them ending up in nursing home. They can't feed themselves, they can't dress themselves, they need helper, they need carer, and they slowly spiral down. And we know proximal humerus fractures mortality is not far off from neck of femur fractures at 5 years. But the neck of femur fracture mortality is plateaus of after 2 or 3 years. The proximal humerus fracture mortality is linearly increasing as time goes, and somewhere around 4 or 5 years they catch up, because they don't die from a fracture, they die from the consequences of disuse. They have another fall, they have another fracture, they lose social independence, and some of them ending up in nursing home, they get depressed, and they pass away.
And you found a mortality difference in your study, right? The operatively treated patients had a lower mortality at 2 years, which is striking.
It's a huge difference. We found in a non-operative group 15%, and a reverse group 1.5%.
In a randomized study, so the groups really should be comparable.
And just remember, this is 2 years, and we know, well, what we don't know, the non-operative group, well, we know it will be even higher.
Yeah.
The other thing not to forget, that the non-operative group is going to run into problems of arthritis, more disuse of muscles and tendons. The function is going to decline with time. They're going to have more and more pain, less and less function.
And what I'm hearing is, yes, they get better forward elevation, but I'm hearing, mortality is a big thing. And so we would never be having this podcast deciding if we should treat femoral neck fractures operatively. And what I'm asking is this similar to femoral neck fractures? Are you thinking that this might become
I think it's going to be very
standard of care?
Currently, it's quite difficult to prove, but I feel reverse will save lives in the long term. Just adding a small study, we're looking at when you have a neck of femur fracture and you have an associated shoulder fracture at the same time. The shoulder fracture, they have both injuries, 50% increased mortality within admission, which is within 30 days. So just to have a shoulder fracture with your hip fracture, which we will always fix, but we most of the time forget about the shoulder fracture, 50% increased mortality. So what I started to do is we fix the hip fractures, they get a quick optimization and pit stop, and I do a reverse 2 or 3 days later or within a week, and get them mobilized, get them out of bed. Because a hip fracture patient with a shoulder fracture associated, you can do anything with a hip fracture, they will not mobilize.
And tell me about your rehab protocol and how that's changed over the years. It sounds like you're trying to get them onto a trajectory of quicker recovery.
So I think that you mentioned a couple of studies in the past comparing no difference. The problem with those studies, I feel, they were variable age range, some of them all over 80. So we had a bit of a better variety of age range, 60 and older. And we have a longer follow-up of 2 years, some of the studies only 1 year. And those studies, they all immobilize the shoulder for 6 weeks and then start active movements. My goal is function. Currently, they get an abduction brace for 2 weeks to get the tuberosity fixation started to heal, then 2 weeks in a sling for more comfort, but from day one, they start active rehabilitation. Usually I limit them elevation 90 degree and external rotation 20 degrees, so not to load too much the GT. And after 4 weeks, active full range of motion. The non-operative treated patient, more or less the same. They were in 3 to 4 weeks in a sling. They starting range of motion as pain allows. But they're not having this prolonged sling or immobilization. And I think what's the benefit of this? They get this early pain relief and functional benefit from reverse compared to the non-operative treatment. And I think that's crucial, why we find significant difference compared to other studies.
And I think what's so interesting to me about this is this kind of research, a randomized clinical study, is what really should change our practice. And I think it's hard to not look at this and think that the reverse should be the dominant treatment for the elderly patient with a displaced 3 or 4 part fracture. I mean, do you think that's accurate, or do you think that we still have more work to do before we can make that statement confidently?
No, I completely agree. And if you really look at systematic reviews or Cochrane, the problem with Cochrane, again, it puts together displaced, young, old, 2, 3, 4 part fractures. And if you really look at the literature, only 5% of the literature discuss non-operative treatment for proximal humerus fracture. 70% talks about any type of surgery, and only 3% of studies are randomized trials.
Right.
So we have very limited evidence. Mm-hmm. But when you really look at, there's a lot of systematic review, when mix and match. When you really look at systematic review with level 1 evidence, looking at displaced 3 or 4 part fractures, the reverse is a gold standard already. So I think we have enough, and hopefully this study is adding to this growing evidence that reverse should be the gold standard treatment for these patients.
How does this change your practice, Ian?
Well, I see a lot of elderly patients with fractures as well. I mean, I'm not at a level 1 trauma center, so it's usually kind of cold trauma that's coming in a week or so later. And I struggle with this. I don't want to be overly aggressive, and I think that's one of my duties, your Hippocratic oath, you don't want to cause any harm. But what I'm hearing is I may be causing harm by waiting. And, it's a change in paradigm.
I feel exactly the same. When I see these patients and I say there's multiple randomized clinical trials, they show no difference in operative and treatment, and now I can't say that anymore. I think some of those patients will look at it and say we should probably just do a reverse now when we probably should have done it a week ago.
The other thing I mentioned is the cost. It's all money talks, and that's for the managers. If you really look at now, it's quite a lot of cost effectiveness and cost utility studies showing different treatment options. And if you look at these studies, believe it or not, reverse in a long run is more cost effective than non-operative treatment. Why? Because the reverse has a high upfront cost, no question. But a non-operative treated patient needs prolonged physiotherapy. Some of them need injection and long-term treatment, ending up in a nursing home, need carers. So you need to look at the bigger picture. So reverse actually not, I think, outperforms clinically, but is a cost effective.
Even if it costs more money, if it gives you a better outcome, it could be worth it. So I think you can't make the analysis that simple of what is more expensive.
Correct.
Yeah, and this is not just practice changing, this is policy changing.
Yes.
And I feel like our legislators need to hear this.
And believe it or not, in the UK, we have guidelines for a lot of things, led by BOA and NICE, hip fractures, pelvic fractures, nerve vessel injuries, but nothing for proximal humerus fracture, which is the third most common injury we see. So I try to work now with BOA and BES to come up with what we call the BOST guideline. We are waiting, obviously, the PROFER 2 trial outcome, when we can proceed further, which is actually going to discuss same topic, non-operative treatment, hemiarthroplasty, reverse arthroplasty for displaced 3 or 4 part fracture, which was the biggest problem with the PROFER 1 trial. It was excluded. But I know what's going to be the results, I think.
Well, I congratulate you on this work. Having tried to do some randomized studies on my own, they're extremely difficult studies to do. It's hard to get the patients to follow this long. This is the trauma patients in particular. They come in, they probably don't want to be randomized to operative versus. So it's a huge achievement, and I think another brick in the wall towards our understanding for how to treat these injuries. And so I congratulate you guys on it, and I think it's great work.
Yeah, this has been really enlightening, and I'm just excited that you're putting it out there. I look forward to seeing the next wave of your patient follow-up.
Yeah, absolutely. Well, thank you again for coming to the United States and telling us all about it.
Thank you very much, ASES, and thank you, guys.
Thanks, Peter.
So next up is Dr. Mike Kim from the University of Missouri discuss his paper, Conjoint Tendon Lengthening Results in Improved Interrotation Pain Following Reverse Shoulder Arthroplasty, a combined randomized clinical trial and biomechanical study. Mike, welcome to the podcast.
Well, thank you for having me.
And then joining us as a guest co-host is Dr. Jacob Kirsch, of the New England Baptist in Boston. Jake, welcome to the podcast.
Thanks so much, Pete. Really appreciate it.
So, Mike, I'm fascinated by this paper. Tell us what inspired you to do this study and what you did.
So the motivation I got this from study is whenever I see the patients coming back in the clinic after reverse, some of the patients really complain about linear internal rotation, and some patients, doc, I'm fine. I figure out how to take care of my business in the bathroom. But some people struggle, and I had a question about how are we going to improve this problem? Is there really a problem? And I looked at literature. There were quite a few papers already, and but there was no really clear solution. But there are a lot of papers out there asking how we improve by changing design, size, and offset. So most of the items they're talking about were related about the design of the prosthesis rather than patient factors and other things. And one observation I consistently saw during the surgery was the conjoint tendon, it gets really tight after you put a reverse, but it gets even tighter when you do extension during the surgery. And extended and really tight, and that position, if you try to internally rotate, the inner part means medial part of the conjoint tendon gets even tighter. So maybe this is something is holding the patient's internal rotation. One of the paper from the Christian Gerber's group showed extension is essential to have a functional internal rotation behind the back. And they said about 40 degrees is necessary to have a functional internal rotation. So if something is holding you from getting extension, we have to solve that issue first, which I thought is conjoint tendon. That's how I started.
So I love this idea that tightness in the front limits extension, which then limits internal rotation behind the back, sort of adducted internal rotation. Then tell us what you did in the study.
How I did?
What did you do in the study? Yeah.
Oh, okay. So I did, at the beginning, I was not even thinking about doing a study. I just did a little experiment on my own. I didn't even tell my resident and fellow what I'm doing, but someone said, what are you doing? You're cutting conjoint tendon. Well, I just thought it's too tight. I'm gonna release the lateral half of it. So I start with the lateral half release, and then I got a little more brave. So I'm gonna release 2/3 of it, and then one day I just cut through and see what happened. And all those patients came back, with no problem. And I got the confidence, it's okay. It's not causing any significant problem. And then those patients have some pretty amazing internal rotation, and I got more confidence. So I thought maybe I should do some study.
So then what is the study you did?
Oh, so the study I did was a randomized clinical trial, and I enrolled those patients who are undergoing primary reverse shoulder arthroplasty, and randomized in two groups, lengthening group and control group. Obviously, lengthening group got lengthening, and control group didn't get a lengthening. For lengthening group, I made a Z-shaped lengthening and re-approximate conjoint tendon with the number 2 non-observable sutures. And then we bring back, and whenever they come back for a clinic visit, I just measure their internal rotation, patient-reported outcomes, those things.
And then what did you find comparing those two groups?
Oh, so every study you look at in the literature, it's not really 100% or 0. There's some mixed bag, but when you look at the average internal rotation, it has a significant increase after lengthening compared to control group. And the pain was better. Well, reverse, and after reverse, how many patients really complain of pain? Not a lot. So we're talking about 1 versus 0 or 1 versus 2. That small change, but it was a statistically significant. So after lengthening, patient was complaining less pain than control group.
Then tell us, what is the geometry of the implant you're using in this study? Is this a 135, 155? Is this lateralized glenoid, lateralized humerus? What does it look like?
So the implant I use is a Tournier implant. That the Tournier implant is a performed glenoid and performed humeral stem is a 135 implant. And the socket I used whatever fit better for patient anatomy and attention. So the socket size was not standardized, but the neck shaft angle and glenosphere position is almost all standardized.
Now, one of the worries I've had about the conjoint tendon, because my partner, Dr. Robert Tajan, first described this conjoint tendon lengthening, and we've used it in some settings where there's residual anterior shoulder pain, which is not common, but this is taking it even a step further, which I love. I've worried about instability because I don't have the same muscle tension. I've worried about nerve injury because all of a sudden there's no longer the conjoint that's protected. Like all of a sudden now, if I'm lengthening more, I'm lengthening through the nerves instead of through the conjoint. Tell us, did you see any of those problems in your study?
So I think great take on from my study is it is safe to do that. But if you exercise precaution, so I'm not lengthening from the beginning. So I lengthen almost right before wound closure. I check the range of motion in last minute, check if there's any impingement, how tight it is. If that is really tight, okay, may I just do lengthening? And that's how I do. When you lengthen, if you think about where the brachial plexus is coming from, it's coming from medial superior to lateral inferior. My Z lengthening follow that direction. I'm not going the opposite. If you go opposite, there is a chance you're gonna zip really close to the brachial plexus. I use a bobby for that. I'm not using knife because I have to feel where I'm getting close to the nerve. Yeah, so Z lengthening and then suturing.
Jacob, what are your thoughts?
I think it's really interesting, and like you were just talking about the role of internal rotation, like we have to think about it different than external rotation. Why? Well, you externally rotate in two ways, right? You could externally rotate with your arm at the side, adducted. You could externally rotate with your arm here, right? We could internally rotate both ways. You can internally rotate here, and if you think about your arm in a neutral position, you can internally rotate, but then your torso gets in the way. Right?
Just so everyone listening at home who can't see Jacob as he's motioning his arm, he's talking about internal rotation, exrotation in abduction versus adduction, and describing the problem. When you're in adduction, your hand gets in the way of you fully internally rotating your fingers.
Right, so as you described, when we think about functional internal rotation, it really is a mechanism of extension of the arm, pronation, and then really like flexion of your elbow and a little bit more internal rotation as you come behind the back. So you have kind of three modes of internal rotation where you have one or two of external rotation, right? So, and it, like you said, it makes total sense that if you are tighter in the front, you need that extension in order to get there. And so I do think it's really interesting. I share the same concerns that you had as far as instability, things like that. I think the other thing that's interesting is there are always things that we see and objectively measure versus what the patient experiences, right? We have objective things and the patients have subjective things. And we have patients that come back and they're at 120 degrees and they're like, Doc, my shoulder is awesome. My SSV is 100%, And so there's things that we could measure and then what patients assess. And, when to do it, when not to do it. I share your concern about sometimes when, if you have to go back, if there's instability, now you don't kind of have your safety barrier immediately. So where is that trade-off? It's interesting, having talked with Byram a lot about this. He does a lot of conjoint tendon releases. He'll fully just release it. Won't Z-plasty it. He'll just release it quite often if he feels it's too tight as a mechanism of decreasing anterior shoulder pain. I've never thought about it in the sense of improving internal rotation. So I think it's a really interesting idea. I think it's hard to know which patients do you do it in, do you not do it in, and maybe those OA patients where inherently they're going to be more stable because they have a cuff, you worry a little bit less about instability risk with it, but I think it's a really interesting idea.
Now, can I ask you just functionally, maybe on the technical side of the Z lengthening? The conjoint has kind of like a surface tendinous part and a deep muscular part. Are you doing everything or just the tendinous part?
So that's very important. At the beginning, I was so worried about cutting through this tendon. But once you cut tendon, which is a superficial, you still have a muscle behind it. And as long as you're not going through the muscle, you're safe, and the muscle will preserve some of the muscle function down there. So you're not worrying about losing anything. I have not done any revision yet on those patients, so I don't know what it's like. I don't know whether I'm going to be able to see the tendon or just muscle or holding scrabble. I have no idea. But at least the coracoid is preserved, and based on coracoid position, you probably estimate where the tendon might be. And its tendon is down there, although it's retracted further distally, but you can see those things.
And how far from the coracoid are you doing the Z-plasty? Is it very close to the coracoid, or is it a couple centimeters down?
2 centimeters below.
2 centimeters.
for study purpose, I kind of set in some arbitrary number. That's a 2 centimeter distal from the coracoid process.
And then when you make the Z,
Yeah.
how long is the longitudinal portion of Z? Like how much are you lengthening it?
About 3 centimeter.
A lot.
Long, it's
Wow.
3 centimeter long and then Z. So you get about 3 centimeter length. If you do a little, like a 2 centimeter, I did a 2 centimeter. Yeah, I'm not sure I'm doing anything. So I feel like a 3 centimeters are pretty long. Yeah, I like that better than.
And then you're doing a kind of a figure 8 with a number 2.
Exactly.
Okay.
Yeah.
What did you experience as far as the improvement in internal rotation compared to those people who, when you did it compared to the controls? What was that difference?
So we're talking about, it's not like 100% or 0%. Some people still have like ipsilateral buttock or sacrum level even after lengthening. So I don't know why those people didn't have a greater improvement. However, if you look at the distribution of the patients, a lot more, significantly more patients had like even thoracic lumbar junction, upper lumbar level after lengthening, versus none of the control group reached it that far up.
It's interesting. Did you, because Phil Moroder has published some really interesting data on scapular position and kyphosis and different things like that as far as ability to get internal rotation and stuff
Exactly.
like that. And so I'm curious, it would be interesting to know if, how much that impacts it as well.
Right. We
In those
didn't
patients.
look at because our sample size is 55, so we didn't have a subgroup analysis for those, and we didn't really tease out if their implant size and offset was affecting any of this. But we just randomized, so hopefully the randomization kind of teased out all these confounding factors. But you never know.
Certainly those are great questions for the future though. Might this be more important for the patient with a more upright posture where then they need the extension more versus a more down where maybe it's easier for them to get their arm into extension because their scapula is already in more downward rotation? Or is this more important for the patient who's more lengthened and less important for the patient that's less lengthened? I think these are all things that make sense, but I think it's so exciting that you've done this because it gives us yet one other way that we can improve the reverse and another way that we can address really what is probably one of the biggest unsolved problems right now in reverse. So I really congratulate you on this work. I think it's a brilliant concept from the beginning, and then taking it into practice the way you've done is great. So again, congratulations on the work, and thank you for coming to share it with us.
Yeah, no problem. Yeah, I just want to put a last word as a precaution. I'm not doing conjoint tendon lengthening for everybody. It's a intraoperative assessment, and based on that, the patient is a very thin female, and you lengthen like heck, and you feel really tight, and you're gonna feel like she's gonna have a real limited internal rotation app. Not based on BMI or anything. If intraoperatively really tight, okay, I'm gonna just lengthen a little bit. But even if heavy set male, if the conjoint tendon is not that tense after you put on everything, I'm not gonna lengthen it.
It's really interesting because those are the patients that typically are the ones that get that anterior shoulder pain afterwards. When you look at it and you think, when you're thinking about that anterior conjoint pain afterwards, it doesn't tend to be the big males, it tends to be your smaller female population anyway, so maybe it's kind of two birds, one stone.
Yeah. So this is a kind of segue, but conjoint tendon has something to do with just Peter, you mentioned, and I haven't done a few cases, only a few, I'm collecting more cases, but anterior shoulder pain, conjoint tendon lengthening, and I'm thinking we can do a lot of things arthroscopically. Conjoint tendon releasing, you can do arthroscopically. So I've done 3 cases so far, and I don't know why this is happening to them. Mechanical symptoms, anterior pain, and I went there, and you can release from intra-articular scope, like anterior portal, like you do coracoid, just release it.
Now we're on the
Surprise
bleeding
doctor.
edge for sure, right?
Yeah.
Arthroscopy of the post-operative reverse, I love it.
Yeah.
Well, thank you
that's
again
it.
for coming. This is
Yeah.
amazing, and we'll look forward to seeing your work going forward. We'll look, hopefully by next year or 2 years from now, we'll have the results of arthroscopic conjoint tendon lengthening.
All right.
Great. Have a great meeting.
All right. Thanks so much. I appreciate it. Thanks for having me.
Okay, next up we have Dr. Howard Harris of Texas Orthopedic Specialists here to discuss his paper, Stemless Reverse Shoulder Arthroplasty for Glenohumeral Arthritis with Massive Rotator Cuff Tears, 2-year results of a prospective, multi-center, historically controlled trial. Howard, welcome to the podcast.
Thank you. Glad to be here.
And then joining us as a guest co-host is Dr. Anoop Shah of the University of Arizona. Anoop, welcome to the podcast.
Thank you for having me.
Okay, so tell us, Dr. Harris, what did you do in this study? What was the general protocol here?
This was an IDE study that was FDA approved for stemless reverse arthroplasty, which is currently not available in the United States. So we had to have FDA approval to design the study and then enroll U.S. patients in that study. And there were 7 sites that enrolled a total of 90 patients that qualified for the study through the screening process that we did reverse stemless arthroplasty on. And then we did a minimum 2-year follow-up on those 90 patients. And then you submit that data to the FDA to get approval for that device to be available in the U.S. market, ultimately being the goal.
And what did you find among those 90 patients 2 years later?
The outcomes were very satisfying. We followed outcome scores, multiple outcome scores. We had radiographic reviews, and then of course followed all of our complications or potential complications, adverse events, serious adverse events, return to surgeries. And so I guess the big picture on those 90 patients were we had 92% follow-up. We had 2 deaths that were unrelated to the device, and we had a 3% dislocation rate, which falls within typical literature ranges for reverse shoulder arthroplasty. It's actually on the low end. And then probably most importantly, we had a 2% subsidence or humeral implant migration incidence, which is the main concern with stemless implants, particularly in reverse, which is completely different biomechanically from an anatomic, as we all understand. And so that was one of the main factors we looked at. We only had a 2% subsidence. Those were early in the patients post-operatively when they occurred, and they were early in the series too. So part of that we think is patient selection as well as learning curve for the surgeons when you're doing a new procedure for a study like this. Can be factors that affect that.
So 2%, if I'm doing the math right, basically that's 2 patients probably.
Correct.
Among the 90. What happened to those patients? Did they end up needing to be revised, or did they secondarily stabilize and end up okay? Did they dislocate? What happened there?
There were 2 of them that were revised. That the implant falls into varus, and then it's really a clinical decision. Like one of those patients was mine. As that patient progressed to 4 weeks post-op, we saw increasing subsidence of that implant, and so then we made the decision that we wanted to revise that to a stemmed implant. And again, I think some of that was patient selection, post-operative protocol early on in the series. So I'll take some responsibility for potentially technique related, all things we were paid attention to, we're aware of, and made decisions proactively to try to correct those going forward in our clinical practices.
Now the implant it's a 135, 145.
So we cut all those patients off an intramedullary guide at 145, which is based on some of the biomechanics data out there for reverse that provides the most symmetric loading of the implant. They all had centered humeral components that and a standard base plate and glenosphere construct on the scapular side, but they were all cut at 145 with a 20 degrees of retroversion.
It sounds like overall the results are pretty promising. And would you say that's true? When you looked through the data, do you feel like overall you're satisfied with the results, and you feel like the implant works well enough that you'd want to use it in your practice?
I do. I was very pleased with the results when we went back and looked at my own patients as well as the whole study group, and I think this is it's the sort of the evolution we've seen in arthroplasty with on the humeral component side with standard length stems, short stems, and then in anatomics with stemless implants. And I think that same transition is occurring with reverse. It's happened in Europe. There's a fair number of studies now in Europe on stemless reverse, and that data is promising as well. And so I think it's a useful tool in our toolbox. It's not the only procedure for every patient that needs a reverse, or the only implant option, but it's a useful toolbox, or a useful tool in your toolbox as a surgeon that, for the right patient done correctly, for the right reasons, you can get excellent results and reduce complication risks and improve outcomes.
So, Anoop, as you think about these results and you think about your own practice, who for you would be the stemless reverse? Like, which of your reverse patients would you say, okay, that's probably the person I'd start in?
That's a good question. Actually, that's what I was going to ask Dr. Harris.
Oh, sorry.
No, is demographic-wise, I know we didn't get into that. Can you tell us, your patient selection? Was there a specific criteria based off, bone mineral density, age, sex, activity
diagnosis,
level? Diagnosis, exactly.
So for this study, and like IDED studies, very detailed inclusion, exclusion criteria, all IRB approved. The inclusion diagnosis criteria was glenohumeral osteoarthritis with irreparable or massive rotator cuff tears. We also, and all of the patients enrolled met those criteria. We also, the study allowed for osteonecrosis, and there weren't just any osteonecrosis patients in that group. Mm-hmm. They all got screened for, we did DEXA scans on all those patients, and that's maybe not something you would do in general practice, but it's developing a comfort level with doing a new procedure, maybe something to consider. And we had a pretty extensive preoperative screening process, no inflammatory arthropathies, no steroids, and so we're looking for patients with good bone that would be good candidates for that procedure. And then intraoperatively, we were testing with the typical thumb test, which has been described in Europe, and with the centering pin position, as well as for this implant, there's basically a sounding device where you test your size width, and we wanted good bone quality, and it's peripheral fixation, so it's at epiphyseal bone, and maintaining the cortical rim at the epiphysis of your cut, that where the best bone is to get the best fixation. And George Athwal's done some great work on that as well, and some of the data he's published, and along with the 145 cut being probably the ideal version potentially for this type of implant. And so if they didn't meet all those criteria, then those patients were either unenrolled preoperatively, or they're even I think there were 4 patients that we unenrolled from the study before the implant was ever put in. So that those patients intraoperatively, if you weren't happy with the bone quality, the surgeon had the discretion to unenroll those patients from the study before they ever put the implant in.
So interestingly, you only had 2 complications from these. While that number's not huge, were they in patients that had a diagnosis of primary glenohumeral joint arthritis, or was it a cuff tear arthropathy patient? Just different forces, the chronicity, the centering of the humeral head on the glenoid and so forth. Do you think that might make a difference?
So the one I was most critical of was mine. I had a gentleman, healthy, I think he was 73-year-old, male, good bone. And it ended up the patient selection for the study ended up being about 2/3 male that met the inclusion criteria. So it was, predominance male over female. But in like my individual, he had bilateral total knees before. He was a mechanical engineer. He was very dialed in with doing his rehab and being aggressive with that. And so I think instructions on post-op activities are important. We also, learned sizing of the implant is very important. We had a limited number of sizes that were originally developed in the European market, and this is a large individual, and so looking at my own radiographs post-operatively, I undersized his implant, but it was the largest implant available at that time. Since that time, we've got a larger implant that's available, which meets some of our market in the Texas area better potentially. So I think I undersized his implant. I think we let him be a little too active post-operatively. it's that first 6 to 8 weeks that's critical, where you need to get osteointegration of the implant. And then there's a lot of good evidence that once that implant osteointegrates, it's very stable, because we had no late-term implant migration or subsidence. They were all early. And a lot of the European data represents that too.
So it sounds like one of the lessons learned is that sizing the implant and getting a cortical rim fit with the implant is really important, probably for stemless reverse.
Yeah, the best bone is peripherally at the epiphysis, so making the cut at the right level, at the right angle, in that patient that has good bone, and getting good peripheral fixation with that implant, and having it stable at that time to get good cortical integration is key to get good outcomes on this.
You know, something I'm sure everybody has their different post-operative regimen, and especially since you're really, really relying on this bone to integrate and to heal onto, you know, this stemless device. What's your post-operative rehab? In this multi-center, were they standardized? Was it the same? Were you immobilizing them longer?
Sling for 2 weeks, sling for 6 weeks?
We didn't mandate a particular post-op protocol. We left that to surgeon discretion. Same for slings. So there was most of the surgeons, I think, didn't change their post-operative rehab protocol for reverse. And so there was some early range of motion, you know, sling use is needed, and then they would transition, you know, typically in that 6 weeks plus time frame back to more active motion and activities. But we didn't want to create a protocol that made it mandatory for good results. It needed to perform in standard patient care.
Right.
It was really the device and its function with proper patient selection that we focused on for this study.
Interesting. One other quick question that I had for you from a technique standpoint was, if we know that the risk of subsidence is probably a little bit higher with the stemless compared to a standard stemmed implant or a short stem, are you changing the amount of tension at time 0 when you're putting them in anticipation of, hey, I know the thing is probably going to subside a little bit and I really don't want this to be an unstable construct? Or is that really not an issue because you know they've got the DEXA scan, you've got this very specific patient selection criteria, so maybe that's not even an issue? Curious on your take,
I think balancing that with stability, right? There were 3% incidence of instability in this patient. So doing those surgeries, you know, we were obviously aware of bone density and time 0 implant stability, but you also had to balance the soft tissue like you do with any procedure. So this is not a new procedure, it's just different from a humeral component standpoint. So I didn't intentionally, you know, under tension the soft tissue for fear of subsidence. I think that's the wrong thought process. You need to have a stable implant that will tolerate balanced soft tissue tension to try to reduce your instability risk, as well as provide, you know, functional outcome, and realize the benefits of a stemless component, which is, you know, it's bone sparing, less blood loss, it's less steps. You're not violating the humeral canal. Those patients, you know, in my anecdotal experience, had less pain relief. Our outcome scores were excellent at 1 and 2 year follow-up. So I think a lot of the upside of a stemless component in the right patient was demonstrated in our study as well.
Certainly, those things are all potentially true. The thing that is certainly true should be ease of revision. So if you have a patient who comes in with an infection, not having to remove some sort of diastole fixated component would be a huge difference.
That's absolutely true. Yeah. And fractures. So we had I think 2 or 3 patients that had postoperative traumatic events, you know, later on in follow-up, and had a fracture. And revising those patients is much more like a primary fracture than a periprosthetic fracture, because the fracture stays at the surgical neck, doesn't extend down into the diaphysis with those patients. So I think that, you know, if you view it from a revision or a complication standpoint, those are both benefits.
That's a really great point. I mean, I really feel like we're on the precipice of lots of revision, reverse shoulder arthroplasty, and to your point, Peter, I think that, you know, this stemless really changes the game, especially from periprosthetic fractures and infections and trying to remove these implants. It's huge.
Maybe I'm too young, but every time I do a surgery, I'm constantly thinking about, if this doesn't work, what am I going to do next? And so I think we should all think that way about, how do I make it so that if this patient does have a problem, I'll be able to solve that problem still. I'll be able to solve that problem with minimal morbidity to the patient, and not instead just only thinking about today.
I think that's very insightful. I mean, you plan your surgery for your plan A, but as you do every surgery, you should have a plan B and a plan C in the back of your mind for intraoperative complications, which you should also have your downstream opportunities in mind for that patient don't create problems for the next surgeon or the next time they have a problem and they need your assistance. So
maybe along that vein, you mentioned there were a couple of patients that were converted intraoperatively from stemless to stemmed. Did you encounter, was that a challenging thing to do? Did that create problems with the prep that you'd already done?
No, you're doing a standard humeral cut that you would for reverse, and when you make that cut and you assess the proximal humerus bone at the centrally and around that epiphyseal rim, if you're not happy as the surgeon with the bone quality, if it's the thumb test or the centering pin or your preoperative punch, you put a stem in just like you would for any other procedure. So it doesn't change anything. It doesn't change your workflow in the OR. You've got essentially the same cut you would have for any other reverse that you're already doing. So then you just put in a stemmed implant. So we didn't have anywhere we put the implant in and then, that failed, we got to take it out. Like I said, those patients were just unenrolled because of intraoperative. The bone quality assessment intraoperatively was inadequate to stay in the study.
Well, certainly I think we're all interested to see what the future will hold. And I think anxious in this country that we've fallen a little bit behind the Europeans and what's available to them. So hopefully these data add to what's available going forward. And I certainly know there are other companies that are looking into this, and I'm really hopeful the future, at the very least, makes our lives easier if we need to do revisions, but maybe even better, it gives us better options for our patients in terms of bone preservation.
Agree. Thank you.
Thanks for coming on and taking the time with us. Really appreciate it, and congratulations on your work.
Thank you both for having me. I enjoyed it.
Congrats.
Well, that's all about time we have for this podcast. Thanks you so much to our guests. For all of our Shoulder and Elbow listeners out there, don't forget to subscribe, and we will see you next time.